Hey, this is Dr. Ben Whites, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drwhites.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Thank you so much for joining us today. For those of you who enjoy the podcast, please give us a ratings and review on Apple Podcasts. There's a video version on my YouTube page, and if you go to my website, drwhites.com, you can find complete show notes and a detailed transcript. Today, we'll be discussing stool testing interpretation, parasites, and gut health with Dr. Ilana Gurevich. I recently had a fascinating discussion about parasites with Jason Herlick, and I really wanted to get another perspective on how we should view parasites when they show up on a stool test and how best to treat or not treat them. Dr. Ilana Gurevich is a board-certified naturopathic physician and acupuncturist, and she currently co-owns two large integrative medical clinics in Portland. She runs a very busy private practice specializing in treating inflammatory bowel disease as well as IBS and SIBO and other functional GI disorders. Thank you, Dr. Gurevich, for joining me today.
Thank you, Ben, for having me again. And I would also like to just say in person, your questions, because I listen to a lot of your podcasts, the amount of knowledge that goes into the questions, I stop listening and I get so excited. That you did an osteoporosis podcast, and I swear to God, I probably sent it to 10 people.
Wow,
it's like
cool.
The breadth of knowledge that goes into your questioning. I am sure that you are busting your butt, and it's a ton of work doing the podcast.
Absolutely.
You get a ton.
Yeah.
All of the people who listen get a ton.
You know what? For me, it's kind of cool because I always love school, and I feel like I'm always in school because...
That's funny because what I love about podcasts, especially yours, is I feel like I'm going to a webinar, sitting on my butt and driving somewhere or doing my dishes.
Right.
So thank you.
You're welcome. Thank you. Thank you. I thank you for noting that. So as an introductory question, how's your practice doing in the midst of this, continuing coronavirus pandemic?
So, the positive thing is because I'm so specialized, really my practice very easily transitioned to online. The bummer is what I also do is acupuncture, and that does not transfer online. What I have been noticing is, a lot of the mental health stuff that people are dealing with COVID and isolation, I was trying to put them on meds. Lots of people are suffering from anxiety, from insomnia. I was trying supplementation. I was trying medication. And at some point I was like, can you just come in for some needles? Because acupuncture and getting people back in rhythm, that fixes a lot of the mental health that people are dealing with right now.
Yeah, absolutely. All this isolation, especially older people, it's really makes it difficult.
Yeah. And our clinic, I think, just like your clinic and every other clinic, is taking crazy high-end precautions. But sometimes, a virtual visit, which is totally doable, it does not replace an in-person visit. No,
absolutely. I totally agree with that. And, the chiropractic, there's no way to have 6 feet distance doing chiropractic. So, we sanitize and use masks and require everybody else to use masks. And, so far we've been good. So, knock on wood. So how often in practice do you see a parasite on the stool test that may be playing a role in a patient's health?
Okay, so I'm going to qualify that with my practice is very specialized. So by the time somebody waits to see me, they've probably seen their standard medical GP. They might have even seen another functional medicine provider. So by the time they get to me, they've been through the ringer. And in my practice, for the functional GI disorders, 60%, 70%, I find is linked to some kind of protozoa or parasite.
Wow.
Yeah.
So in general, what if you find multiple things? Because I know one of my standard protocols a lot of times for gut problems, if the patients are willing, is to, when they have these sort of IBS type symptoms, gas or bloating or diarrhea or some of the other type symptoms, we'll tend to screen them for a SIBO as well as doing a good stool test. And it's not unusual to find several different layers, and it's always a diagnostic conundrum. What do you identify as the primary thing to focus on?
So I actually have a priority. It all comes down to taking a really good history. In that history, you want to figure out when their symptoms started. Has it been lifelong? Because if it's lifelong, ever since they're a kid, you're thinking microbiome. It's not likely that a newborn baby had some kind of parasitic infection. So if it's lifelong, then I'm thinking microbiome. I'm going to think small bowel and large bowel. If it's some kind of after a recent onset of some kind of foodborne illness, that would lead what kind of testing I'm going to do. If it was after some kind of international travel, that's going to lead to the kind of testing I'm going to do. And then based on also their symptom conglomeration of symptoms, is it really a lot of bloating, distension, pain, small bowel-like things? There is no good way to rule up protozoa, parasites, or yeast in the small bowel. We have really effective testing for bacteria in the small bowel, but that's it. Unless you're going to do a small bowel aspirate, which no one's going to do. If It's sounding like way more of a large bowel issue, then I'm going to think, okay, I want to go down that path and work up the large bowel. When I get results, I will always prioritize with treating parasites, protozoa, and worms. And the reason for that is I feel like it's really well documented that those things change the microbiome. And so why start anywhere else if sometimes resolving the protozoa or parasitic infection is going to fix the microbiome small bowel issues or the microbiome large bowel issues? And there was a really interesting study, and I can get it for you to put in the show notes. There's a really interesting study on Giardia in particular, where they looked at how Giardia behaves in the lumen of the intestine. And, there are parasites that will go and, get themselves in the intestine of the human, and there'll be blood and there'll be mucus, and that's not what Giardia does. What Giardia does is it changes the microbiome. Right? And so I'm not going to go after treating a microbiome issue if it's going to be caused by a parasite that will then correct if you give the body the right environment. And so I always start there. And worms come first, parasites come next, protozoa come next, microbiome and biofilms come after that. And so that's my triangle of care.
And what's your preferred stool test, or do you use multiple tests?
I really don't. I'm I really love the GI map. I love the GI map. I love it for the money, because they have some insurance coverage. So like $250 with insurance coverage, $450 without. I love it because it also gives me functionality. And the one thing, I had this aha moment maybe a year ago that I was way underdiagnosing exocrine pancreas insufficiency and bile acid malabsorption. I was missing it, and these chronic diarrhea patients were not getting better. And then, what I always do is I convince somebody to pay me to give them a talk. And then I go and do like this really deep dive into what do we know about it in the literature? What do we know about it naturopathically? What are our mentors doing empirically with treatments? And when I started realizing this was a huge chunk of my IBS patients and a little bit of my IBD patients, it just changed everything. And so the GI map gives me that too. Right.
I know some practitioners will do a separate test that's maybe more specialized on just the microbiome.
I feel like what we are assuming we know about the microbiome is way more than what we actually know about the microbiome.
Right. Yeah.
But I will also say, when I'm looking at the microbiome stool tests, there are a couple of things that trigger my thinking. One is Pseudomonas. I feel like with Pseudomonas, I am assuming that if I see a Pseudomonas on a sample, there's going to be a biofilm there. And then that will shift my thinking to A, if there's a biofilm there, I could be really missing protozoa, parasites, and worms because they're hiding. And B, I'm not seeing the whole test, like the whole pathology test is a little bit of a question mark because I think things are hiding behind the biofilm. Strep and staph are the other things that sometimes pique my thought process about biofilm. Pseudomonas always does. Strep and staph, if they're high, then that will also inform my thinking.
So if staph comes up at all, but maybe it's still within the reference range, do you worry then?
I think it depends. I think it depends on what the rest of the test is looking like.
Right. And do you think there's a problem with false positives with PCR testing for parasites?
I think that there's a bigger issue with false negatives than there are false positives, but I think there is a likelihood for having false positives as well. I mean,
right. Because there's kind of been a debate over the years about what's the best way to determine parasites. And, one of the thoughts or criticisms of PCR is there could be potentially evidence, DNA evidence of a parasite that's no longer there?
I don't know. That seems very counterintuitive to me, because if they're segmenting, if they're taking the DNA segments,
right?
And I will be honest, I have not looked at the literature for this, but if they're taking the DNA segments, then I feel like if it's not there, what am I seeing? I feel like that there's a study that really changed my mind about DNA PCR, which was in 2016. That it's my favorite study. They compared ova and parasite sugar salt stain, immunofluoroscopy, and DNA PCR with known Giardia. And, it was so gross. Like the ova and parasite was something like 17 cysts per sample. The sugar salt stain was like 300 something cysts per sample. Immunofluoroscopy found 117,000 segments, and DNA PCR found 300 and something thousand segments. And so then I was like, okay, well, that's amazing. And that tells me that's the best one to use. But they also found that the testing was 56% sensitive. No. It was 64% sensitive. So 56% false negatives.
Wow. So
was my math? No, 46% false negatives.
False negatives rather than false positives.
False negatives on that particular study. And, I tried to find any literature that I could on comparatives of the different stool testing assays. And that was the only study I could find. Yeah. But I haven't looked in a couple of years.
Yeah, no, we're big fans of the GI map as well. But I know some practitioners like to use 2 stool tests. I know Rishi always talks about using like a PCR test and a culture test. Or
I think it would be amazing and expensive.
Right. Yeah. That's always an issue.
Yeah. So.
Okay. So let's talk about some parasites that show up on a stool test, like Blastocystis hominis and Diantamoeba fragilis, that may or may not be pathological depending upon, what article you read or who you listen to.
Mm-hmm. So, I do generally go after those and treat those. I've listened to Jason Haralick. I think he's an amazingly intelligent person. I think he's been in practice for a long time. And after I started listening to his talk, because he's out now talking a lot about Blastocystis homini and Diantamoeba fragilis, and I pulled back on treating them. And I tried to do a lot of the other things, and I just was not getting a great amount of efficacy. And I have been really narrowing in parasites and protozoa for probably the last 7-8 years. And I feel like by the time they come to me and they have these unresolved symptoms, going after the parasites and protozoa, it does make a big clinical difference. It really does. So for Blastocystis homini, I usually use a longer course of Alinea. I find that it's been the most successful.
How long a course is that?
21 days. Okay. I use 21 to 30 days straight. For Giardia, I'll use 2 10-day courses. So do
you do like 10 days, stop for 10 days, and do another 10 days?
Around the full and new moon, because I'm still a naturopath. So, I'll have them, what I do is I look at the full and the new moon, because there's so much empiric evidence and such a history of parasites in the moon cycle.
So maybe you can explain where this is coming from.
So there's a huge amount of empirical information about, during the full moon and during the new moon, the parasites are going through their cyclical cycle of hatching and laying eggs. I will also say that I come from a long line of psychiatrists, and my father happens to be an incredible holistic psychiatrist, and he will always say, it's a full moon. Everybody who's teeter-tottering on that edge of sanity, they're going into a hospital. And so, I come from this history, and then as a naturopathic physician, you just see that people feel worse around them. They get crazier. Like it feels like the water is boiling a little bit hotter around the full moon. And so what I'll do, the way I'll cycle it out, it's a little bit confusing, is I like to treat for 10 days. So I'll look at the next full or new moon and start treatment 7 days before and go 3 days after, right? So a 10-day cycle. And then we give them a break until 3 days before the next new moon or full moon, start then and go for 10 days. And in the interim
and by the way, the rationale is that the parasites, first you're killing the parasites and they may have laid eggs, and that the eggs are not going to hatch while you have the antiparasitic drugs in the system. Correct?
And then if they have fungal overgrowth, that comes up too, or maybe some kind of microbiome stuff, I might use herbs in the middle of those 10 days. Just to really try to cover as much, because remember, parasites and protozoa change the microbiome. And if you're trying to get much more to a functional microbiome, kind of help supporting that with herbal antimicrobials can be helpful.
Now, I know a lot of patients are kind of apprehensive about taking like antifungal drugs, and there are, a certain amount of side effects that occur depending upon the patient. So, what are your favorite herbal protocols?
You know what my favorite product is, which I can't get right now? My favorite herbal fungal product is something called Clear 4. It used to be called Candid Clear 4.
Oh,
it's
okay.
by Pharmax. I swear to God, there is some kind of magic in that product.
Huh.
And so the way that product works is it's like garlic, cinnamon, oregano, and a probiotic. And there are 4 tablets, or there's a tablet and 3 capsules. And I think maybe it works so effectively because I'm dosing it 3 times a day. The tablet, which is mainly garlic in the morning, the 2 middle capsules with lunch, and the probiotic for dinner. And it's a 30-day course. But for fungus, I find that there is nothing that I find as effective as that particular product for fungal overgrowth.
And what about for the parasites instead of Ilana?
I have never had good success with parasitic treatment and not using drugs. Ever. And I tried, but I'm not an herbalist. I think that herbalists are probably going to be more aggressive than I am. How much Mahonia can you really have somebody drink before they want to kill you and they're not compliant? So, I feel like I've heard things about Mimosa pudendens.
Right. Yeah.
I've heard about that. I've tried wormwood. I've tried black walnut. I've tried Paragard. It just never. I tried it for years. Sorry.
Yeah, no, that's okay. Everybody has their own experience. We get pretty good results with wormwood and some of the combination products. We use Paragard and a concentration of wormwood and garlic, and I guess some of the data shows garlic can be very effective.
Yeah. I will also cop to the fact that I might be lazy. There's definitely that possibility.
Right. And so if you have a patient who has SIBO and a parasite, and you treat the parasite with Ilana, do you find that the SIBO resolves, or do you need?
So, at times, for sure.
What percentage of cases do you have to go ahead and treat the SIBO afterwards?
So that's a really interesting question, because if they come in and they look like they have a large bowel predominant issue, I won't test for SIBO. So sometimes they come in.
What does that mean? They look like they have a large bowel predominant problem.
So for me to do a small bowel workup, I'm looking for bloating. I'm looking for belching. I'm looking for reflux or GERD. I'm looking for some kind of distension. Diarrhea might be there, but there's something that's telling me that the small bowel is trapping some kind of gas. Because I feel like, you have air in your stomach, you burp. You have air in your large bowel, you fart. You have air trapped in your small bowel, you bloat. And there is an appropriate amount of bloating that happens to all of us after eating. But if it seems excessive, and people are showing me the pregnant abdomen pictures of just bloat, that's a small bowel workup for sure. If they are not if bloating is not their issue, if it's more constipation, if it's more diarrhea, but there doesn't seem to be like a big small bowel component, I'm going to start by looking at the large bowel.
I always have trouble with this whole bloating thing. It's hard to sometimes correlate when the patients complain about bloating with what we see, and some patients complain about bloating, and we sometimes have a tough time figuring out exactly what's meant by bloating. Sometimes they say they have bloating and it doesn't appear to be any bloating, and they feel it. And then we have some patients that complain about bloating, and I think they're probably just, some cases, overweight, not really bloated.
I mean, I think I totally agree with you. I listened to Ruscio had this podcast a couple of years ago with this doctor out of the UK, and he was like a tertiary specialist, like to get through the NIH.
Oh yeah, I think I heard that guy.
It was really interesting because he basically was like, there are two forms of bloating, and he had like he had this belt that was created called a bloatometer. Yeah.
The bloatometer.
Basically exactly what you're saying. There's like the internal pressure that people feel but don't look distended. And then there's the physical distension that you can see, that you can measure with like belt loops.
Now, because theoretically, the small intestine doesn't really expand very much. So, and that's why they feel bloating when there's gas in the small intestine, whereas they don't feel the bloating when it's in the large intestine because it's able to distend. So I always wonder, how can it really be that they have this big bloated stomach if it's coming from the small intestine, which really can't expand very much?
I mean, I think I think it depends on their morphology. Like I had a patient who I saw yesterday, and she was complaining of bloating. That's her biggest complaint. And she was like, this is about average, maybe a little bit. I'm looking at her abdomen, and I was like, that looks completely normal. Like, I think that there's also that picture of like dysmorphia, which also plays into some of this.
Right.
So I think it is a tricky thing. But if they're telling me that that's one of their symptoms, I'm going to start with the small bowel first. If they're telling me that their symptoms are more defecation related, then I'm going to start with the large bowel first. And I'm going to start looking at what I can find in there. And then if we treat and they're not getting a lot better, then I might reflex to a small bowel test. So that's where I'm tricky. That's where it's tricky for me to give you a percentage, because it depends on their history of where I'm going to start a workup.
So when you say a small bowel test, essentially you're talking about the SIBO breath test?
I'm talking about the SIBO breath test.
Okay.
Mm-hmm.
Are there any other small bowel tests that you utilize now?
There's a lactulose mannitol, which I think is a small bowel marker. I don't use it very much, despite the fact that I think it is the gold standard for intestinal permeability.
Right. Now, I want to change the topic a little bit. H. pylori is something that shows up on stool tests. Mm-hmm. And the GI map does a good job of having these virulence factors too. But do you, if you get a stool test back with elevated H. pylori, and let's say maybe in patient one, there's no virulence factors, do you do additional H. pylori testing? Like some doctors will order the antibody test or the antibody test, or what's the other test? The breath test for H. pylori. Yeah.
I feel like I feel like if I see a virulence factor, if I see the CAGA or the VACA virulence factor, I'm going to move forward with treatments.
So only those two?
Only those two.
Really?
Yeah.
Okay.
Because it has been it has been shown that those two are the ones that are most likely to cause issues. You know, what ended up changing my mind on this was, did you ever read that book, Missing Microbes?
I know about it, but I never read it.
He made a really good case for the fact that if they're not symptomatic, H. pylori might really be one of the controllers of the microbiome. Right. And so if they're not symptomatic and I see H. pylori, I don't want to kill anything that I don't. And that's triple antibiotic therapy. You know what I mean? Like,
right. We use herbs, but yeah.
Yeah. I mean, I'm not going to go after it. If they're symptomatic, I think it's a different conversation. If they've had ulcers in the past, I think it's a different conversation. And if they have those two virulence factors, I think it's a different conversation. But generally speaking, if I see it, I say I'm not worried.
So for people listening to this podcast who might not know, H. pylori is generally understood to be the cause of ulcers in a significant percentage of patients. And it was something that took a long time to finally be discovered. And the doctor who originally discovered this, Dr. Marshall, had a tough time with the medical community accepting it. And he actually scoped, he had himself scoped, and he drank H. pylori and then had evidence of an ulcer, and then took this triple antibiotic therapy and had evidence of improvement. So H. pylori is now considered a significant potential pathogen. And it usually operates in the stomach rather than intestines, and it's burrows into the wall of the intestine and leads to acid production and ulceration and stuff. So, but maybe it's a question of degree. Maybe we want a certain amount of H. pylori as important for the health of the
that
stomach.
Was his theory, and I feel like symptomatic is very different than a random finding on a test.
Have you used the Herbal protocols for H. pylori?
I have a couple of patients who had. It's a lot of work, but they actually have had success. I have one in particular who was like, she was using mastic gum.
Yes.
She was using oregano. She was using meadowsweet. Actually, she was one where I was like, girl, we had a positive H. pylori with virulence factors. She was scoped. They found it on scope. She treated it. She was re-scoped and it was gone. So I think you can totally do it. I think it's a lot of work, but I think you get a lot less side effects doing it that way than doing it with the drug.
Yeah. I know in my practice, we have a lot of patients who have a history where somewhere along the line, they got put on some antibiotics that seem to play a significant role in their gut health getting much worse.
Word. Yes.
Right. So let's see. Any other parasites we want to talk about?
So, dianthropomoeba fragilis is an interesting one. Okay. I feel like that also is the one that causes a lot of symptoms. And that's
another one that some people say is normal to a healthy gut.
Yeah. So that one sometimes responds to Alinea. There's one study that says that God, I never remember how to pronounce this medication. Praziquantel palmitate works a little bit better. I also will use tinidazole for that one sometimes. I feel like I feel like it will change the microbiome. And so that's why I go after it. And then, oftentimes treating it gets improvement.
Right. Any other parasites that you see regularly?
Yes, I see. Endolimax nana is a tricky one because I'm not sure. I feel like I'm more on Harlick's side with Endolimax nana. I feel like I've seen it and it doesn't present how I expect it to see. And sometimes I treat it and they don't get better. So that one I won't go after with drugs. I might give them some antimicrobial herbs for that one. So that one's a little bit of a question mark for me. Those are the three that I see more than anything else.
Okay. Do you see Giardia?
Oh, I see. But that's a parasite. I don't think anybody's going to argue with you that you treat Giardia, you treat crypto, you treat Entamoeba histolytica. I don't think anybody's going to argue about that. That's not even controversial.
Right. Now, it's one thing I find interesting, coming back to the concept of the stool test, is there's at least one marker on the GI map for inflammation, and it's not unusual for my practice to see patients who have some significant issues in their gut, a lot of symptoms, and you sort of assume they'd have a lot of inflammation, and they may not at all.
You're talking about the calprotectin or the zonulin? Are you running zonulins also or no?
Do you run zonulin regularly?
I run it on everyone, yeah.
So now that's a measure of leaky gut, right?
Right. So that's the reason why I find that useful is it's the only small bowel marker on that entire test. Like that is a large bowel test except for the zonulin, because zonulin is literally a small bowel marker. The controversy with zonulin, there's a couple of controversies with zonulin. One, all of the research is coming out of this one particular lab. And so, that's always a question if people are can revalidate what that lab has found. So
is that Fasano's lab?
Mm-hmm, yeah. And then the other controversy with zonulin is there are a couple of studies that are looking at zonulin and, things that you would expect to make improvement in the zonulin doesn't always. And I'm thinking dietary interventions in particular.
Right.
So I feel like that lab's an asterisk, and I feel like it doesn't add very much cost. And that is the only thing that guides me towards, should I be also looking at the small bowel?
I guess for me, I started running it, and it seemed like we didn't get a lot of positives. And I felt like most of these patients must have leaky gut based on their symptoms and history. And yet this test is saying they don't. So I thought, I wonder if this is really worth it.
So that's funny because I had the opposite thinking with it. My thinking was Okay, so if it's not positive, that means that most likely I need to focus all of my attention on the large bowel. And if it is positive, then I need to start thinking about the small bowel. And the other thing that I've discovered kind of haphazardly through clinical practice is quercetin works incredibly to heal up zonulin, which is interesting because I feel like
just by itself.
Just by itself, I use it at really high doses for a short amount of time.
What's a high dosage?
2,000 milligrams 3 times a day.
Oh, wow. 2,003 times a day. Wow.
For 1 month. Because it does interfere with thyroid conversion of T4 to T3.
What?
So, yeah.
Quercetin reduces thyroid conversion?
Especially at those levels.
Wow. Well, I've never used those levels, but it's interesting because we're using quercetin a lot in the immune strengthening protocols.
I'm using it a lot with viral/COVID.
Zinc transporter, yeah.
Yeah. And it's phenomenal. It's like, it is phenomenal for that acute viral conglomerate.
Right, but what are you usually using, 250 or 500, 2 or 3 times a day?
Yeah, I'm, 10 times more than you.
Oh, really? Wow.
I mean, 2,000 3 times a day. And that's what I'm using for the acute URI COVID protocols also. But it works phenomenally. It also works phenomenally. There's one study that showed that it's really good for healing up the leaky brain barrier also.
Really? Interesting.
I mean, it's like for post-concussion syndrome, I have a great doctor I work with, Dr. Lori Mincato, who is very, very well versed in post-concussion syndromes, who I sent all my MCAS concussion people to. And she also, I have this one patient who I sent to her. I saw her for GI, but she had a post-concussion history for like 5 years. And she was like, start her on quercetin. It's amazing to heal up the brain barrier as well.
Wow. Well, you would expect that something that could help heal the leaky gut would also potentially help the leaky brain. Yeah, totally.
And so what will happen, the way I'll use that in the Formex of a GI map test is I will look, if I treat the large bowel, I'll figure out what's there, and then I'll do a GI restoration protocol. And if zonulin is elevated, I'll really push quercetin in that protocol.
We'll do that after you're done getting rid of the, bacteria or parasites.
Because, if you kind of have to change the terrain to kind of heal everything up in there.
Right. So what's your favorite gut restoration protocol?
Oh, okay. So quercetin is definitely in there.
Okay.
I love zinc carnosine. Are you using zinc carnosine?
We go back and forth on it.
There was this.
We tend to use like a combination formula that has some zinc carnosine in it. It has glutamine.
Oh, like Endozen by Claire. Do you use that one?
I haven't used that one. No, we usually use like the what's it? GIFX? No, GI.
Yeah. That one's got a lot of things.
GI Revive.
That's
right. The Designs for Health.
Designs for Health. Yeah. That one has a lot of things in there. My only issue with that one is it doesn't have high enough quercetin. That's my only issue with it.
Interesting. And so you said how much of zinc carnosine are you using?
75 once to twice a day.
Okay.
If they have a lot of small bowel stuff, glutamine's always on my differential.
Now that zinc carnosine is not going to raise your intracellular zinc levels because it's acting in the gut, right?
No, zinc carnosine is it's not naturally produced at all. They take a zinc molecule and they bind it with an L-carnosine. It's made in the lab. And the reason why I like it so much is because they have a couple of studies that basically show that for ulcers that were created because of radiation. So these are esophageal cancer and stomach cancer patients. What they use zinc carnosine after treatment and before treatment, and it took these radiation-induced ulcers from a grade 4 to a grade 2, or it stopped them from producing as actively. And so if they're doing that, if they've shown that with radiation ulcers, there's no way that
interesting.
It's amazing.
What about the patients who have like fibrosis from radiation that they had?
I think it could be too late. I'm not sure.
Too late. Yeah. We've been using a modified citrus pectin because that supposedly helps with fibrosis. Working? A little bit.
You know what I think about for those people?
Yeah.
Is frequency specific microcurrent.
Oh, okay.
Just because I feel like I don't know if anything I'm going to give them orally because it's so scarred over. I feel like just changing the way the cells work, which is what frequency-specific microcurrent does.
Yeah, I wonder about maybe infrared light too.
Yeah, exactly. I'm thinking more like that to like return on the cells to function.
Right. Yeah.
So.
Yeah, there's actually some interesting studies using infrared light for hypothyroid, Hashimoto's.
Oh, really? Like localized over the thyroid?
Yeah, exactly. Yeah, there's some group out of Brazil that did several studies and got like really interesting changes in the parenchymal cells in the thyroid, actually, significant reversal of this autoimmune process.
And, that's not a very expensive intervention.
No, I know. Exactly.
Yeah, that's really interesting, actually.
Yeah.
Huh. That's really interesting.
So what else part of your gut restoration protocol?
So quercetin, zinc, carnosine, glutamine, maybe. Probiotics are always going to...
What do you mean glutamine maybe?
So glutamine if it's a small bowel. I'm not using glutamine so much for the large bowel because I feel like, the enterocytes, glutamine is their preferential treatment for food. But the colonocytes, it's something like 10%. Like colonocytes really prefer butyric acid for their food. The trick with that is I've never seen butyrate ever. I've never seen butyrate do anything helpful.
Okay.
So
you mean you're talking about taking short chain fatty acids like butyrate separately as a supplement?
Exactly. And I mean, maybe rectally, but that's also expensive and uncomfortable.
Right.
So
then you got to feed them the right prebiotics to produce the short chain fatty acids. And they have to have
a microbiome that will accept the prebiotics.
Right.
Or the patients to go through the die-off that happens when they're converting their microbiome. So, but I am loving prebiotics right now. I would agree.
What's your favorite prebiotic?
So I use two. Life Extensions it's called Fluorosist.
Okay.
Which is it's a chewable. I think it's XOS. And then I use a lot of Microbiome Labs. They have the mega prebiotic, but that one, people who don't tolerate dairy won't tolerate that one.
Right. It has FOS, XOS, and GOS. Yeah. Yeah.
So those are the two that I use. And it really is if you tolerate dairy or not.
Right. And then do you have problems with patients who have SIBO taking some of these?
So I don't start there. Right. So, I'll go through a treatment round. And then, one of the things that I have been really, really playing around with, which is interesting, is using all 3 or 4 classes of probiotics simultaneously. So I'll start them in a class 1 Lactobacillus bifido at 75 to 100 billion.
This is like Ruscio's class.
I totally got it from Ruscio. I mean, he's a very smart thinker.
The problem I have with that system is, when you look at all the data on probiotics, so much of the data is strain specific. So to just basically take 90% of probiotics and go lactobifido.
Okay. Yes, I agree with you. That being said, I feel like the goal is just diversity, right? How do we get any amount of anything? So when I'm using my class 1, the one that I'm using is Probiotic 10 by Protocols for Life Balance or Super Probio by Kirkman, right? I like those. And they've got 10 strains. You know what I mean?
Right. But the thing is this is getting back to the same concept is there's actually been really fascinating research done with, lactobacillus, NCMF, 1463. And that particular one has a certain therapeutic value that, just having 10 different ones in that category are necessarily going to have.
Absolutely. And there's also been really interesting studies that take these combination formulas with Streptomophilus and a couple of the species of Lactobacillus and some Bifido and maybe some S. boulardii. And those seem to have efficacy too.
Right.
I feel like it's never in the human body, which is so complex.
Right.
You're never going to be able to isolate for one strain of probiotic.
Right.
Which is why I'm okay, let's throw it all at you, and then let's throw in a prebiotic.
So when you say 3 strains, you said a combination product, a Saccharomyces boulardii, and then a Bacillus, spore-based, yeah.
And then sometimes E. coli Nissel, 1917. And so I'll do that for a month, and then I'll throw in a prebiotic for a month, right? Because I'm trying to get it to hold. Because, the problem with probiotics, at the end of the day, the problem with probiotics is they're kind of like air conditioning. When you take them, you can get people to feel better. When they stop taking them, they go back to the diarrhea they were having before. That's just a waste of money. I don't want somebody on a pill.
Well, it's also because you're taking some grass seeds and just throwing them across the ground, right? So they're not necessarily going to take root. So you need the prebiotics, which is the fertilizer and
Right. And you obviously need the foundation of every kind of functional medicine. You need them to have a good diet. You need them to be eating fermented foods. The more, the better. You need them to be eating fiber naturally in the diet, so they're not relying on a pill. Like, all of that goes without saying. And you know what's interesting is
it's really hard to get like 40 grams of fiber a day, not taking an additional product.
I would agree. And I think that patients who seek out functional medicine or naturopathic medicine are way more motivated than the standard American patient. And so if anybody's going to do it, it's totally going to be them.
Right.
And a smoothie can get you, it's amazing how much you can shove into a smoothie.
Yeah. What I have in the morning, I don't think you could actually call it a smoothie, but
exactly.
Kind of like this black goopy mess, but
you've met all of your dietary needs in one meal.
Exactly. Okay. So, I think that about wraps it for me. Any final thoughts you want to leave our listeners and viewers?
Yeah, I just really want to say it's complicated. It's complicated. And, it's the nice thing, the luxurious thing for me being as specialized as I am.
It's complicated, and you've got to be patient if you want to restore your gut health, right?
I mean, and can I just, there's this one clinical case that just kind of blew my mind. There was this patient, she came in to see me, and she flew in to see me so that I can manage all her meds and all her labs and all that. And she was on 40 supplements, 50 supplements,
wow.
Every supplement under the gun. And then I was talking to her, and I was like, you're also having all of these crazy menopausal symptoms. You also are osteoporotic. It's actually not even safe for you to be with no estrogen, right? And so really, I took away 2/3 of the supplements, and I started her on bioidentical hormones. And that was the missing link of getting her to poop. You know what I mean? It's so complicated. And that getting a good history and working with somebody who actually does this on a regular basis, it's really helpful. It's really helpful.
Part of this, I think, is because, treatment by Google, and the patients start layering, and they start chopping practitioners. I'm sure you've had patients that do that to you, and, they call you up and they get a consultation, and you're now number 17 in a line of practitioners, and they've taken part of what everyone has put them on. And so they're layering this group of supplements on top of this one, and they were not meant to be taken simultaneously. It was like that practitioner or that article's recommendations. This would be your protocol, not to take that plus this one, plus this one, plus this one. And the same thing with diet, where you follow this particular diet that takes out, these 3 food groups, and then another diet that takes out 4 more food groups, and a third diet and pretty soon there's no fruits to eat.
Right. And not, you didn't even mention that they're paying a mortgage in supplements.
Right.
You know what I mean? That it is, I think that's why, granted I'm biased, but I feel like working with a clinician, because supplements are not made for, okay, if A, then B. You know what I mean? Supplements are made for, this is the whole picture. This is obviously the priority. Why would we do anything else if the priority isn't working? Because you are literally just pooping money out your butt.
Right.
It's difficult because the internet is so accessible and not everybody has access to care. And I live in Portland, Oregon. I have 13 naturopaths in my practice. You know what I mean? People who live in Florida, they see some functional medicine doctors who run all these tests and then put them on all these supplements based on the tests, but not looking at their symptoms. I understand it is not easy. And I also think if you want to try to figure out yourself, I totally respect you trying. And if you are flattening out, I think getting some extra support is really helpful.
Absolutely. And I also think if you can find the right clinician who's giving you a reasonable treatment protocol based on some reasonable amount of testing that makes sense, you should stick with that practitioner, because I think sometimes all these different, you're talking about 50 different supplements, comes from, I did a consultation with this person who put me on these 6 different things. And then I read this article that said, take these. And then I did another one with this one. And,
yeah,
I think that's part of the problem.
Yeah. And I also just want to say, we live in this amazing world where information is so accessible, which is amazing. Like, never in our history have patients been this empowered to take their own care in their own hands and really guide their treatment plan. And, we no longer live in the world where, doctor is God and whatever doctor says I'm going to do, which, right. By the way, I would love for somebody to be like, yeah, just tell me what to do and we're done. It would make my job easier. But that, we don't live in that paradigm anymore. It's really important to educate yourself. Right. And it's also really important to understand where your education falls short on the internet.
Right. Yeah. And I think at this point, there's so much information out there that our job is really to try to streamline and teach the importance of the right information rather than just provide more information.
Right. Which is, I feel like, what is luxurious about my job specializing, because I only need to know about, I'm like an inch wide and a mile deep. I don't need to know about your kidneys. I know you have kidneys and I know they're important, but I know what I know. And so I love staying in my lane, doing this thing and then let's get you somebody who's more of a generalist.
So how can patients contact you if they want to utilize your services?
So you can find me on naturopathicgastro.com. And the nice thing about my clinic is I do have residents who work under me. So if it's cost prohibitive, the residents are much cheaper. And, we will do educational consults, which means that we can, talk to you, do a FaceTime visit or do a Zoom visit, and then get your history and kind of give you our thought process. If you come in to see me, then I can run your show for a year and do all the labs and all the pharmaceuticals and all that, but we can definitely give you our brain. And when you work with me or the residents, you work with a whole team. So you've got 3 brains on your case as opposed to 1.
And do you offer training programs for clinicians?
So I did my first one. I did 9.5 hours on inflammatory bowel disease, standard of care, and naturopathic interventions for inflammatory bowel disease.
Was this part of Narola's program?
No, I did one for Narola. I did 4.5 hours for her. Okay. And then I bloomed it into 9.5 hours.
Okay.
I did one class specifically on rectal ozone, which might be my favorite treatment for inflammatory bowel disease. I did a naturopathic protocols. I did drugs for inflammatory bowel disease. And that one is probably my biggest soapbox, because one of the things that I feel like naturopaths and functional medicine doctors do wrong is they're in this big hurry to get patients off their biologics. And that is very, very risky, because biologics form antibodies. And if they're well tolerating their biologics and they're not having any side effects, there is no point of taking people off the meds. The meds are not the enemy. The enemy is the bowel deteriorating and wasting away within the human, causing pain and symptoms.
Cool.
And so go on.
No, go ahead.
So that you can find also on my website, Naturopathic Gastro, on online teaching. And that is approved for continuing ed for naturopaths in the whole country through April 2021, I think.
Oh, wow. Cool.
It's burly. I was great. Like, God bless you for listening to me talk. I mean, I think anybody hears me talk and they immediately become anxious because it's so fast. So God bless you for
I'm from New York, so it's normal for me.
That's the problem. That's exactly the problem. If I was from South Carolina, nobody would be anxious around me.
Thank you, Ilana.
Thank you so much, Dr. Weiss. I really appreciate it.
Okay. I'll talk to you soon.